Welcome, everybody. I'm glad you made it with me over to this session. This is session two of today's conference, and our speaker is Lindsay Corcoran. Lindsay will be sharing with us from gap to growth how one hospital built a swing bed program to improve care delivery. When local skilled nursing options fall short, rural hospitals often face difficult trade offs, longer inpatient stays, increased transfers, and challenges keeping patients close to home. In this session, Lindsay, a principal at Strawwater, will walk us through how one hospital developed a swing bed program from the ground up in response to rising inpatient length of stay, local quality concerns, and a commitment to improving access to care within the community. Through her work supporting rural hospitals and medical practices across the country, Lindsay has helped organizations strengthen operational and clinical performance, improve access, and evaluate strategic growth opportunities designed to sustain care delivery in rural communities. This session will explore how swing bed became more than just a simple service line addition, evolving into a broader strategy to improve throughput, strengthen community trust, and enhance patient care delivery. Handing it off to you, Lindsay. Thank you.
All right, great. Thanks so much, Amy, for that introduction. So, welcome everyone. Thanks for joining today's session on swing bed services. And really, this is kind of a real world example about how one hospital was able to kind of build a swing bed program, or actually still actively building that swing bed program to improve care delivery. So, we're really going to have be able to kind of walk through and really understand the why behind adding swing bed services to their suite of services at this particular rural hospital. We're going to look at and talk a little bit about the business case, kind of validating the opportunity. What are the steps that we looked at to really understand what this opportunity and how it presented to this organization? Then specifically, we'll talk about how the program it looks and feels for this organization. Really looking at the design of the program. What were some of those gaps and lessons learned throughout this swing bed program evaluation? And then also, what were some of the key aspects of implementation? And we'll walk through what an implementation framework looked like for this particular rural hospital. The rural hospital that we're talking about is AdventtHealth Manchester. They are a rural hospital, 49 beds, PPS hospital, so a short-term acute care hospital located in Clay County, Kentucky. They are the only Kentucky-based hospital within the AdventtHealth health system, and their community is really a rural community and located kind of in Appalachian, kind of that southeastern foothills of the Cumberland Mountains. So very rural, kind of southern parts of Kentucky. And they provide a wide range of healthcare services to the community. They are the primary healthcare provider, an access point for their community. And when they presented some challenges that they were experiencing to us, what they presented was as that they were the only hospital kind of serving their primary service area, they've noticed and recognized that there was limited kind of post-acute care services, limited skilled and local nursing homes availability and capacity. They know that because they had patients that were leaving their communities for post-acute care, they saw their referrals out of their community for this level of care. And they recognized and heard from many patients and families that it is a burden. It's a burden for them in an area where transportation services are limited and families having to take on that transportation burden to go and visit a loved one that is outside of their service area, up to 50 miles away at a skilled nursing facility, and the lack and challenges around continuity of care of these patients that they were referring out of their health system to other skilled nursing facilities. So we know that this was the challenge that they presented. We'll talk a little bit more about some of the specifics drivers of the challenges, but at the top there, the folks at Manchester really understood that this was a current challenge for them, and they really wanted to evaluate the opportunity around adding swing bed services. So there are certain, kind of, you know, trade-offs, if you will, facing rural hospitals every day. And many of your organizations may be experiencing some of these challenges as well, some related to capacity constraints. And where you may have folks from a capacity constraint as it relates to your own acute beds, not being able to get folks out and discharge them appropriately to the next kind of level of care. Those other post-acute care providers may also be having some capacity constraints as well. This is what was happening in the local community of Manchester, there then that has that downstream effect of adding new admissions into your organization, whether it's an admission from the emergency department may be backed up or maybe needing to transfer because we have that capacity constraint that's occurring. There's also, challenges around patient out migration. We know that we likely, if we don't have the services locally, we are referring out of our health system. That means that folks are going to have to travel long distances, as we mentioned, and the other caveat too is around revenue leakage. When we don't have services to keep folks local and keep them in-house, we are referring out, we are losing money potentially if we could be offering that service. So swing beds really allow hospitals to solve for some of these problems, right? We're looking at improvement of throughput. We're looking at how we can add swing bed services to retain patients locally. We're looking at swing bed services to help support and maintain that continuity of care of our patients. And for some organizations, we're creating new reimbursement opportunities. We're creating a new service line, and we'll talk more about some of those kind of financial benefits as well. Specifically for the folks at AdventtHealth Manchester, they were experiencing some of those kind of impacts on why it drove them to pursue swing bed implementation. And some of the areas that we looked at and identified, they had inpatient volumes that fluctuated. It was summer months that they found themselves, underutilized in terms of inpatient volume, and they had staff that had capacity, right? So they also saw over year after year declining inpatient volume. So at the same time, summer months are experiencing a decline in inpatient volume, as well as, just this year over year contraction of inpatient utilization. They also had a length of stay that really ranged from almost 4 and over 4 days. And that was really impacted by the shortage of available local skilled nursing facilities and swing beds for post-acute care for their providers. Many of them were at capacity, which then in turn impacted the folks at Manchester to be able to get patients out in a timely manner, so increasing that length of stay. Then we had some readmission from post-acute care providers, and the impact of some of those readmission rates. We saw 39% readmission rate from home health agencies that they were referring patients out to, a 27% readmission rate from skilled nursing facilities. They had diagnosis that were associated with COPD and heart failure and sepsis being the most frequent that they saw readmissions coming back to their organizations from those post-acute care providers. And then a few different kind of key kind of drivers around the decision to pursue swing bed services is that they saw 88% of their internal referrals out of the organization had a discharge disposition to a skilled nursing facility. So, a high number of referrals getting discharged to skilled nursing facilities. There was, almost 71% going to one local skilled nursing facility that actually was very much at capacity, could no longer, accept a lot of new referrals and patients. And then that, in turn, Manchester folks would have to look outside of their general local service area. And then we did, the organization did do a estimated kind of pro forma as it relates to swing bed services, and this will come up when we talk about some of the financial impact. But they did estimate a net revenue per patient per swing bed day at about $913. And really just the impact of some of these numbers here, they really wanted to kind of get a handle on, especially, length of stay, having some capacity given some of the fluctuations in inpatient volume, the readmissions, these were all key factors in their decision to pursue swing bed services. As I mentioned, also, there's certainly market realities happening, and these are some of the what's happening for folks in that Manchester area needing skilled care. And as I mentioned, there was only one skilled nursing facility in the primary service area of Manchester, of AdventtHealth Manchester. While if you look out, in a 50-mile radius, there is, a number of skilled nursing facilities, but many of them had high occupancy rates up into, average was about 86% occupancy rate. So again, some capacity issues occurring in those outside of the service area skilled nursing facilities. And, at the same time, although if we look at quality, because we want to make sure that we're sending our patients to skilled nursing facilities that do have higher than average quality ratings, there were certainly some fluctuations that were occurring at many of those skilled nursing facilities that we looked at. We did see trends that even, low scoring facilities on the quality side actually had higher occupancy rates as well. So we also saw that, of course, there's the travel barriers that are occurring, given that we're having to go outside that primary service area, of course. And many of the referrals to the local skilled nursing facilities were for things like, septicemia and severe sepsis. So very kind of high acuity patients that were needing that skilled service. What we also realized from a strategic opportunity, we have the market reality, what's happening, what's going on in the market, and also from a strategic standpoint, is that we know that the organization wanted to keep folks local. They are a pillar in their community today. They wanted to keep folks in their community, and they wanted to continue to really improve outcomes and care delivery for their local community. They also knew that they could be capturing a percentage of those folks that they were referring outside of the organization to other skilled nursing facilities. And what also made the realization that swing bed services could be a good fit is that there was actually a regulatory change happened in the state. In 2025, the state of Kentucky removed the certificate of need requirement for swing bed services specifically. So they were allowed to add in swing bed services without having to go through a certificate of need requirement. And we know, certainly how painful those could be. So this was a real benefit for the organization, almost, gave them permission to go in advance and really think about swing bed services more strategically. And I think what's really important and something to consider, and really just a key takeaway here, is that certainly timing matters in strategy. And things that happen from a regulatory perspective, changes or shifts that happen, can really open the door for some of these opportunities. So just keep that in mind as you and your organization may evaluate, things like swing bed or additional services, and that, any changes that happen on a regulatory perspective can really open that door. I do have a poll that I do want to launch. I didn't launch the first one because I forgot. just because we're rolling. But I do want to launch this poll just to engage you all a little bit and try to understand what's the biggest post-acute kind of challenge that your organization faces today. Is it around capacity of local skilled nursing facilities? Do you experience kind of those delayed discharges? Are you seeing readmissions from your post-acute care providers, staffing, workflow, workforce limitations, financial pressures, care coordination? So we'll let this sit here for just a moment and then we'll close it right up. So if you have a moment, just answer this poll. That'd be great. All right. We're almost just about at 50%. So really nice. What we're seeing here is, uh, you know, capacity at local skilled nursing facilities is quite high. I think care coordination and transitions actually was the highest in terms of a challenge for post-acute care. So whether it's, how you work with and with those other post-acute care providers on that care coordination and the transition of that patient to that level of care. Seems like that might be a challenge there for folks. So thank you all. We do have another poll. I'll make sure that I'm a little more timely on launching that, but we will have another poll as well. All right. And then if you're, maybe this should have been a one that was at the beginning, but what are we talking about when we talked about swing bed services? And I just want to make sure that folks, that, we know that critical access hospitals are swing bed eligible organizations. There are swing bed services can be provided in rural PPS hospitals. There are certain requirements for that. You have to have 100 beds or less. And you do not, you follow SNF, skilled nursing facility, PPS billing and reimbursement mechanisms. So there are certainly some differences as it relates to the swing bed services provided in a critical access hospital versus a rural PPS hospital. But again, similar and very much the same levels of care. You're seeing the same types of patients, folks that are needing and meeting skilled criteria. Those could be folks that might need IV antibiotics, or that maybe they have complex wounds, or they have some type of post-operative need for rehabilitation services. Maybe they have, maybe they're medically complex. Maybe they have needing some type of disease management, all can be qualified as eligible patients for skilled nursing services in a swing bed. As I mentioned, some of the key requirements, specifically that third kind of column in there, is specific to a rural PPS hospital. And, as we all know, Medicare guidelines, we have to have a 3-day acute inpatient stay before being able to be swung or transitioned into a swing bed program. We have documentation requirements as it relates to meeting that medical necessity and skilled care requirements. We have physicians that have requirements as well. And we have what's called care planning, right? We bring together an interdisciplinary approach to care planning. That's really at the core of swing bed services. We have folks from rehab, we have nursing, we have case management, we have social worker, we have dietary folks all coming together and really supporting that patient, moving that patient, advancing that patient, meeting goals, and really progressing that patient to get discharged back home or back to a prior living situation. And that's really the beauty of the swing bed, in addition to some other kind of nuances related to the swing bed program. For the rural PPS hospitals, right, we have a different payment mechanism compared to a critical access hospital. But there's the value that's created in that continuity of care. We're providing post-acute care services for our community. And it's an opportunity to reduce admission, right? Readmissions. We are keeping that patient in-house. We're not relying on the care of others. We know that we have a certain level of expectations within our own organization to provide that level of care to avoid any type of readmission. All right, so now let's talk a little bit more kind of about why this really became a strategic and financial imperative for the organization, for the folks at AdventtHealth Manchester. First, let's, really look at the financial opportunity. We built two different kind of scenarios, one being more of a conservative scenario, which is scenario number two, really grounded on some assumptions via MedPAC. Then we also built in around the folks at Manchester's own pro forma for their service line. We put together some assumptions around a low growth scenario and a high growth. If, low growth scenario would be capturing an average daily census of 1.5. High growth was doubling that, a census of 3. And you can see, in the more aggressive scenario, we're ranging from a contribution margin to about 503,000 to up to $1 million. In that more conservative kind of estimate there, contribution margin both from a low growth of 214,000 to a higher growth scenario of 427,000. So, really there's both kind of, even the conservative, the scenario number two, really created some positive margin there as well. And even with, modest, right, 1.5, even a modest ADC volume really could impact and change performance for the organization. So couple of different scenarios. We didn't, in this case, didn't get into and really dig deep. This was just, we knew that they were going to pursue swing bed services regardless of some of the financial impact, given that there was such a community based kind of relationship building. It was also impacted a lot of other kind of components of their organization that they felt were really necessary to drive home and meet the mission of the organization. And so that's really the focus and what we pursued. But again, understanding from a financial opportunity is valid and very important. They also, another caveat here, the folks at AdventtHealth Manchester were also a mandatory participant in the team model. And if you're not familiar what that is, it's the Transforming Episode Accountability Model. It began in January of 2026. And basically, it's a bundled payment arrangement. And so CMS has decided, based off of some geographic areas across the US, there are certain organizations that are required to participate in this model. And really it's really looking at reducing the cost. We're really managing the cost and improving the quality of 5 surgical categories. There's lower extremity joint replacement, surgical hip femur fracture, coronary and artery bypass graft, and spinal fusion and major bowel procedures. The emphasis is really around reducing any of those readmissions, length of stay management, and care coordination with post-acute care. So, the hospital, they're going to be doing, maybe they're doing major bowel procedures. They then, have a post-acute care plan for that patient. Maybe it's home health, maybe it's skilled nursing, whatever it may be, that goes into that bundled payment, right? So really the point being, AdventtHealth Manchester is then on the hook for the cost and the quality of anybody they refer out of their organization from a post-acute care perspective. And so bringing swing bed services in-house, because swing bed services does meet that post-acute care kind of care setting, if you will. It was a decision that they wanted to make to support their patients within this model as well, and really bringing them in-house. So This was just, again, another way that, given this regulatory shift that was happening, they felt and wanted to really pursue swing bed services, and really meet the needs of their patients within this bundled payment. I know they did have some lower volume for many of these procedures, so I think they only actually had one of the surgical procedures meet that threshold of 30 or more cases. And so they are only required to really kind of meet the requirements of one surgical procedure. Also, just to put out there, as we're talking about team, CMS has also proposed another similar bundled payment arrangement, and this is called the Comprehensive Care for Joint Replacement Expanded Model. And very similar approach to that, looking at the post-acute care, and the cost and the quality. The difference being that it's for a 90-day period post-discharge versus the 30-day post-discharge of these five kind of surgical categories here. So there is this would be something that would launch in 2027, and it would be a mandatory bundled payment. So depending on what your organization does as it relates to joint replacements, and I think it's only PPS hospitals participating and not critical access hospitals, but something to keep your eye out on as something that is proposed with a similar aspect to team. And then lastly, for this, the building the business case around swing bed services, this is for them, it's not just a service line. There is some strategic components around this. And, when we think about all of these various pillars here, it's around throughput and building community trust and really creating, a revenue stream for the organization, and even quality, right? These are going to, influence and have an impact on organizational wide performance for this organization. So, things that they evaluated really, um, uh, were impacted by these pillars here. And so we really allowed them to kind of navigate and understand the impact that these will have from a strategic perspective, and not just, another service line for the organization. So let's look a little bit more into what this is going to look like, or what it has been looking like from an operational perspective to really build the program. And what we started with, in partnership with the folks at AdventtHealth Manchester, was around a readiness assessment, because we really wanted to understand where they are. And the readiness assessment included four key domains around, evaluating their leadership and their culture. Do they have some, leaders within the organization that are really going to champion this program? Is there somebody that we can, hold accountable to the success, to even just building the program? So really understanding where they are from a leadership and culture perspective. Um, at the very top, mind you. And then, clinical infrastructure. Do we have the necessary resources that is going to be in place to launch a service line, to launch swing bed services? Do we have that strong kind of clinical infrastructure? Then we had looked at kind of the compliance and the regulatory. Are they in compliance? Are there gaps in policies, procedures, meeting CMS guidelines and regs? Will we get to the point where they're ready for a survey? And then lastly, around kind of the financial and the operational side of it, making sure that this was a sound investment for them, that we had things from an operational side that will, and specifically for the patient-driven payments side, is are those workflows built in that we can, from an operational side, tied to the finance side, that we can get paid for the work that we're doing. All of these kind of factors really needed to be assessed. We need to understand if there were gaps and what was going to be what was it going to take to be able to have a successful launch, and what that looked like for the organization. And I think having and starting with this kind of readiness assessment or is is a really a structured way to make sure that we're not starting something and it's only to set us up for failure, right? Or put us at some type of compliance risk, because that's certainly the last thing that we're going to want to do. So, starting with a readiness assessment. And the folks at Manchester, they really weren't starting at zero. They weren't starting with nothing in place, and they had a lot of really good things already going for them and in place. So we really built on some of the strengths that we identified, and were able to kind of leverage those strengths to make sure that we could implement swing bed services successfully for them. So they did have, a strong leadership team, engaged leaders. We worked directly with the chief medical officer, the chief nursing officer, and a nurse manager. That trio was really the team that, pulled in necessary resources. They were the ones that were bought in and were being held accountable for the success of the implementation for swing bed services. They had a really great quality culture. They had, various activities that were built in that we knew, they're going to be able to turn on some of the requirements for swing bed very easily because they built this strong kind of quality culture for their organization. They had the key components from a therapy standpoint. Sometimes, if you are starting from scratch, not having the therapy component or rehab component can be really difficult. We know that there are some workforce limitations, hard to recruit therapy services to rural communities, but they did have physical therapy and occupational therapy already on a contract basis with an organization. And they had, certainly the capacity to expand. They had recently added OT services, and they had speech therapy services that were on an as needed basis. Other things that were favorable for them, they had available capacity from a bed standpoint. They also had strong case management. They were able to, they had for their acute patients today, they had really good discharge planning processes in place. They were already, through they were already evaluating, very early on in the patient's stay about kind of post-acute care choices for that patient, and really collaborative across the team. So almost really checking that box for that interdisciplinary team. And then lastly, certainly a strong community presence. And I think when as it relates to swing bed services, I always think, swing bed services are almost like an outpatient service. It's referral driven, it's relationship driven. It is almost like an outpatient service because we are, patients have a choice of where they want to go. They can, stay in our organization. They can be transferred out somewhere else. How we get referrals from other organizations is developing those relationships with case managers. So the folks at AdventtHealth Manchester already had a strong kind of community presence, and to be able to really kind of launch that program. And so, really want to make sure that if you are evaluating swing bed services, is really don't underestimate your existing infrastructure. You likely have a lot of the key components already in place to really make swing bed services work for your organization. So just keep that in the back of your mind. And then also within kind of building the program is that we looked at kind of, again, those four pillars, right, for the organization. And what were some of those key considerations, and how did that impact, how are they impacted by the addition of swing bed, right? So from a strategic perspective, we are keeping folks local. We're not referring out to skilled nursing facilities. We're really enhancing kind of our brand of AdventtHealth Manchester, and as a comprehensive kind of community provider, providing that post-acute care across the continuum here locally in Manchester. Then from an operational perspective, right, we're helping to offset some underutilized beds. We recognize that we had some seasonal dips, and that's going to help when we do have inpatient volume that dips a bit in the summer months. Um, and also moving folks across, or discharging folks more appropriately from the acute stay and transitioning them to swing bed to really kind of help with some of that length of stay as well. From a financial perspective, having that positive contribution margin, really even looking at it from a more conservative reimbursement assumption, even that 1.5 ADC generated that positive contribution margin. So having that financial opportunity for the organization. And then from a regulatory perspective, or sorry, a quality perspective, we know from a readmissions, they had experienced those readmissions from other post-acute care providers. Swing bed services are going to improve that oversight, that continuity of post-acute care locally and within the walls of their organization. And so hopefully that reduces some of that, those readmissions, and really overall just really aligns with the organizational mission of AdventtHealth Manchester. And that they're really positioning swing bed services as that strategic lever for really care delivery, throughput, and long-term sustainability for their organization, and not just thinking of it as, another service line for the organization. So with anything, right, we know we had strong opportunity, but certainly with any implementation, there will be gaps that present themselves, and they are very real for the organization. And so we did have some gaps that the folks at AdventtHealth Manchester had to close, from ranging from policy and compliance. I think that was a big one. And there was certainly a lot of work that had to be done as it relates to compliance. They did not ever, maybe it was like, 15 years ago, maybe they had swing bed services. So things have changed quite a bit. Policies need to be added, to be reworked. We needed to make sure that we were setting the expectations that there were certain compliance aspects of swing bed services that they needed to implement. There were gaps in education of staff. I know we had folks that were really jazzed up about adding swing bed services, but also didn't have a clue about them. So there was, certainly a lift around education, staff education, competencies around how this is a patient that's a lot different than an acute patient, and we're providing a different level of care. And how do those differentiate each other? We had a hospitalist group that was, again, very supportive of adding swing bed services, but had no experience with swing bed in general. So we also had some gaps in workforce, specifically around the MDS coordinator, so the minimum data set coordinator. That was somebody that was never in place. And, so that was a significant gap, because that's a core component, core team member of swing bed services for this rural hospital. Technology, they were on Epic, and there was no kind of template or structure that existed in Epic for this organization as it relates to swing bed services. They had some hospitals within the system that were critical access hospitals that had swing bed services, but the different mapping and some of the different documentation templates were a little bit different. And so they needed to do a whole big build out. And that was something that was significant and missing for their organization. They had some restrictions around space limitations. Although they had bed capacity, they didn't really have a lot of extra space to maybe do therapy services in. And so they really had to kind of think through what that space would look like. Then, from a program design standpoint, there were some, who owns the program, what's our kind of our overall operating model going to look like for our organization? What put the flag in the sand around this is what the AdventtHealth Manchester swing bed program looks like. That didn't exist. And again, these are some of these gaps that we had to work through, or at least identify, and then start to work through from an implementations perspective. And in every gap that we identified is certainly solvable. If we can think about how we plan for it, how we can work through it from an implementation standpoint. We did have certainly some, specifics around staffing. I mentioned the need for swing bed specific education. That was certainly a gap across, many of the staff members that we encountered, from nursing to therapy to the hospitalist group. We didn't have an MDS coordinator, and that was certainly a requirement and a need. They first evaluated whether or not that was going to be something that they would have to recruit for, or is there somebody in-house that we could go and have certified and get trained with a resource already in-house. And so, they were kind of discussing and kind of dabbling between what route to take. Then, there's certainly, they had the therapy component covered, but at one point, if we're going to grow our swing bed volume, at what point do we need to think about, is this a factor of being able to cover the growth or the volume at a certain threshold with the current complement that we have of therapy? And so something certainly to keep in mind. And then, given that it was a contracted service, are there triggers within the contract from a volume perspective that we maybe need to renegotiate the contract, or really kind of think about that a little bit differently? And then from a hospitalist perspective, there were a lot of questions around understanding what they needed to do from a documentation standpoint. What do they need to do from a certification standpoint? And so having some of that training and the education was essential for them. All right, I'm going to pause for just a second. I do have my third poll, and it's really around which area would be the hardest part of launching a swing bed program at your organization? Maybe you already have one, and I think we have an answer down there for you already have a swing bed program. But if you don't, what would be the hardest thing that you can think of that would really impact your ability or the success of launching a swing bed program? I can see we have a lot of folks that already have a swing bed program in place. But maybe you'll take away from this, maybe some growth opportunities potentially, maybe how we can evaluate our current program for, from an operational perspective, for an improvement perspective, things like that. All right, we're over 50%, so we'll end the poll here, but we are, what trickles to the top right is things like regulatory and compliance readiness. That was probably the top. And then generating a consistent patient volume was also right up there. So, making sure that we have that strong referral pipeline. And sometimes for organizations to be successful from a volume perspective, we can't just rely on our own internal volume, right? We have to start being proactive and doing that outreach to really get folks redirected to our organization for services. So another thing that we worked through from a kind of a identifying some of the gaps and some of the lessons too was, what were some of the more appropriate candidates for swing bed services at AdventtHealth Manchester? And you can see here, There were, given that we sent a lot of folks out with septicemia and sepsis, was IV antibiotics and PICC line patients something that they should focus on. We know that they are in that team model, right? So we know that that is going to be a source of their referrals to post people with the patients with those post surgical procedures will be certainly a priority for them. But we went through kind of an exercise of what were those types of patients that would be appropriate for the folks at AdventtHealth. We also identified who would not be appropriate. They were, if there was a patient that needed close medical monitoring, if they are not able to accept patients with trachs or ventilators, or that had kind of significant behavioral health or suicidal ideation, were something that they weren't appropriate for the program at Manchester. And so really important for organizations from a best practice perspective is to be proactive about identifying patients who are appropriate or not appropriate to your swing bed program and having that really defined. And then utilizing that information for either going out and capturing additional referrals from outside organizations or through your own interdisciplinary rounds and identifying, based off of what we've determined is an appropriate candidate who makes a lot of sense for our own swing bed program. And this all leads to kind of the top recommendations from the evaluation that we did with the folks at Manchester. And it's really built on around looking at governance first, having that leadership buy-in, having that governance being the driver of what happens throughout the whole kind of implementation of swing bed services. We identified that they really needed to get a jump start on their Epic build out. Given that a lot of what we do within the swing bed program, from a documentation to a billing to a coding, all happens within the EHR. We really needed to get that moving. And given that they are within a system, right, things sometimes move a little slower. So we had to get a jump start on that. We needed to make sure that we were educating folks at every role. So whether you were therapy or hospitalist or nursing, what is it that is specific to them that they need to be held responsible or they need to know about swing bed services? We wanted to make sure that workflows were mapped and implemented. What's going to happen? What does our process look like from the screening and identifying folks qualified for swing bed to admission all the way up to discharge and follow-up? What does our process look like for that? We need to make sure that we were validating that financial pro forma for the organization, and then thinking about preparing for any type of survey that the organization would receive. This organization is Joint Commission, so there are, certain timelines and things that they need to consider specific to Joint Commission. We also wanted we took a phased approach in terms of implementation. And, certainly from a phased approach made a lot of sense. And because we know that there are certainly different priorities and priorities are weighted a lot differently. And by taking a phased approach, we really could focus on, the things that we needed to do in the shortest time period versus some of the things that would be a little maybe longer in terms of what we have access to in terms of resources or the bandwidth that it needs to take or the timeline it needs to take. So everything was really done from an implementation standpoint in a phased approach. We did make sure that we built in some pilot testing. So before full launch, it was, let's test a traditional Medicare patient and, internal referral and see how it goes. And I think that's really important. Let's pilot something. Let's really test with small, because we don't want to just kind of go out gangbusters and really think we're going to grow the program, get all this patient volume, and things in terms of our process are broken. So some of the success factors are certainly, and I keep reiterating that, but it's that executive sponsorship, having that core team of the CMO, the CNO, and the nurse manager really made it so easy for this organization to really get things moving. The education and workflow clarity are certainly aspects that really can make it a success. So, what did that implementation look like for them? Again, we did it in that phased approach. It was a timed phased approach. So, phase one was 0 to 1 month, and then so on. And early phases were really focused on kind of closing different policy gaps, the staff education, starting those epic builds, and then, really moving towards, okay, we're ready to accept that patient. We're going to get that survey done. We're going to hit, check the box. We're ready to go. And so working through each one of these was really essential for the organization. And then lastly, I think it's so important for organizations to make sure that as you enter into any type of new service or something, is to understand if you're being successful. How are you going to measure success? And if we can't, we need to make sure that we're not just kind of entering into something because it feels good, although it's great to do that, but how are we going to measure success? And some of these were implemented by the folks at Manchester, but again, these are just some examples of some key performance indicators that can really start to drive improvement and really kind of demonstrate success of a swing bed program for a rural PPS hospital specifically. Uh, and lastly, I'm sorry, I'm like rushing through this and I don't mean to. I know I'm recognizing I'm close to time, so we might not get to all the Q&A sessions. But lastly, how does this apply to your organization? How can you all kind of evaluate readiness for something like swing bed services? And is this, right for your organization? What are some of those key questions to ask around bed capacity? Is there unmet need in the community? Do we have the therapy services available to us? Is there a level of readiness that they have? Did they have do they have capacity, right? Do we have case management bandwidth? That's one thing that I hear, and was certainly a concern going into AdventtHealth Manchester was does the case managers, because sometimes there's a heavy lift on case management as it relates to swing bed services, do they have can they take on the additional work? Do they have that capacity? Do we have to add additional resources? Do we have an EHR that's going to allow us to be compatible with swing bed services? And do we have a leadership alignment? There's going to be no organization that really starts perfectly or is perfectly prepared to turn on swing bed services. But key questions to kind of ask yourself, is swing bed right for our organization? And when we think about some practical next steps of what you can do today to start to answer that question, what about looking at SNF data, referral data? What's the volume? What types of patients are we sending out to local skilled nursing facilities? Because if we added swing bed services, those referrals might be able to stay in house, right? Do we have capacity? Maybe we have really high acute census. We have a limited amount of beds. We have a high acute census. Acute is our priority, right? We don't have the capacity to add on, an ADC of 3 to 5 swing bed patients. Maybe we have a capacity to add 2, but is it worth it to our organization? Have we identified champions? Have we done maybe a quick pro forma to understand kind of contribution margin? And have we done a gap analysis as it relates to everyone's favorite policies, procedures, conditions of participation as it relates to swing bed services? So then for some rural hospitals, right? Are you part of a bundled arrangement? Because there may be, a reason why you might want to pursue swing bed services because of that specific arrangement and payment model. And we can really assess these kind of next steps pretty quickly. And so think about what that might look like for your organization. And then success can look we can have success in 6 to 12 months potentially. I think as you saw from that implementation framework for the folks at AdventtHealth, we had a 6 month implementation timeline. We had a date in mind. We knew that there was going to be some time around, getting the Medicare 855 in, their approval, working with the state, that kind of thing. Those were some of the hangups. But we had, from an operational perspective, and what we could control in-house, we had an aggressive timeline. But they also wanted and felt that it was necessary to really get started with swing bed services. So you could, really look at a 6 to 12 month launch for swing bed services. And, things that we should highlight from a success factor: stable census, lower readmissions, positive margin, and we offer a compliant swing bed program. So, in conclusion, um, really, at the end of the day, swing beds are not simply just kind of regulatory programs, right? There is we utilize them for patient access, financial sustainability, throughput, care continuity, and really, for some organizations, it really aligns around the mission, community need as well. So it can be an opportunity for a lot of organizations. With that, Amy.
All right. Thanks, Lindsay. I know that we are at the top of the hour, and several of you have submitted questions through our Q&A box. We don't have time to answer them right now, but feel free to put your questions in there. Lindsay will be answering them after the session, and we will get the answers out to everyone as part of the conference. Her contact information is there on the screen, so feel free to reach out to her as well. But thanks, Lindsay, so much for sharing a practical look at how swing bed programs can support both operational performance and local access to care. And to the audience, as a reminder, when you exit today's session, you'll receive a brief pop-up. It'll be a survey that helps us continue shaping future conference programming. It should take less than a minute to complete. And if you're joining us for the next session, I'm going to be in that session too. Please return to the conference lobby, click into that session from the agenda, and we will begin again at the top of the hour. So I will see you there. Thank you very much, everyone.
Thanks all.